The American Medical Association recently released The Future of Health, the Emerging Landscape of Augmented Intelligence in Healthcare report, which outlined AI's current role in healthcare. This provides a common vocabulary around AI and reviews the risks and opportunities associated with the design, development, and use of AI in practice. Tonight, we are honored to have Dr. Margaret Lozovatsky, AMA Vice President of Augmented Intelligence in Healthcare. She describes herself in some interviews as a general pediatrician practicing as a pediatric hospitalist and will continue to practice, this is a quote, will continue to practice because it is important for her to see patients and experience why physicians out there are experiencing what they are experiencing. Dr. Lozovatsky is a nationally recognized leader in informatics and has a passion for using technology to improve patient care. Thank you for being with us, Dr. Lozovatsky.
Well, thank you so much for having me. Thank you, Dr. Church. Really appreciate the warm welcome and the great introduction. You even had a quote in there, so thank you. I am thrilled to be here to talk about a topic that I love, which is clinical technology and specifically AI, as it is top of mind for all of us. I'm going to share that I'm a little under the weather, so I'm going to try not to have a coughing fit, but just FYI, that's why I'm drinking my tea here. If we could move on to the next slide. So I want to start off by showing you what you already know and experience on a daily basis. This comes from research that was done by the AMA, and these are the forces that all of us are experiencing when we're seeing patients. And I love that this graphic is as overwhelming as it is, because some days that's what life feels like. And it's important for us to think about, how does technology fit into this picture? And we all recognize that we've sort of had the promise of technology helping with all of these forces that we're experiencing on a daily basis. And my team, as Dr. Church said, I am the VP for Digital Health. Our focus is on clinical technology and how can we use technology to help alleviate some of the pressures that we're experiencing on a daily basis. You go on to the next slide. The AMA did some foundational research, and what we found is that most physicians are thinking about clinical technology with these 4 questions. And what I think is really interesting is over time, this has remained true, which makes sense. And I suspect what's behind each question has evolved over time. So the question of, does it work? In the early days, maybe we didn't trust that our prescriptions went to the pharmacy. Today, that question is a lot deeper. We really expect our technology to work for us in all aspects of clinical care. We continue to think about payment and liability. Those are always top of mind. And we really want to make sure that the technology works in our practice. My needs as a pediatric hospitalist are different than an orthopedic surgeon or a dermatologist or a cardiologist, et cetera, et cetera. And so we now expect our technologies to be tailored to the needs of all of our specific clinical practices. Next slide, please. This slide is a snapshot of the strategy that the AMA has taken from a digital health perspective. And it really goes back to that initial view of all of the forces that we're experiencing and how we want to get to a place where technology is an asset to us. And I like to take it a step further and really call out that we are there to take care of patients, and we really want the technology to enable our ability to take care of patients. So not only do we not want it to be a burden, we want it to be an enabler. It's something that should make our lives easier. And so the mission of our team is to find ways to continue to drive towards that vision, and thinking about the technology as a life cycle, from the development of the technology all the way through to implementation and our adoption use of those tools in the clinical settings. And when I say technology, much of what we think about is the electronic medical record. And most systems have 300 to 400 other technologies that are integrated to the electronic health record. So it really needs to be a seamless experience for all the things that we are interacting with on a daily basis. Next slide, please. And so how does the AI fit into this very complex technological landscape? I want to start off by just some basic definitions. The term AI gets thrown around a lot. So when we hear AI, we typically think of artificial intelligence. And what that really means is intelligence that is able to perform human tasks. At the AMA, we have recognized that we do not believe that clinical technology is going to be able to perform the tasks of clinicians. And so we think of AI as augmented technology, augmented intelligence. And that's really an alternative conceptualization that focuses on this role of AI being assistive to the clinicians. And so the idea is it's going to be there to help us care for patients, and we recognize that the physician role continues to be at the forefront of patient care. Next slide. This is a busy slide, and I want to walk you through this because this really talks about the fact that AI as a concept has been around for a long time, and there's two ways to think about AI. It's the techniques and the applications. And there are many techniques that are utilized within augmented intelligence. Some are rule-based, so they're pretty straightforward, where you have logic in the system. A leads to B leads to C. And some require machine learning and deep learning, which means that we are training these technologies based on knowledge that they have to perform particular tasks. And natural language processing is a technique that takes out of narrative. So when you write a note, it extracts discrete elements. So if you've ever heard people say you have to click this button because otherwise I can't capture it, the idea of natural language processing is you don't have to do that anymore. It can pull out these pieces of information out of your notes. And then there's applications. And so applications of AI include things like robotics. Some of you may have heard of Moxie, a well-known robot that roams some hospitals' hallways. And that has been largely used for equipment and other sort of repetitive tasks. And then there's computer vision and generative AI. And generative AI, you've heard of ChatGPT. That's the overarching term for ChatGPT. ChatGPT is an example of generative AI. And one of the things I want to communicate with this very busy depiction of all of the different things that AI can and does do is that many of the techniques that are here, we've been using for years. We've been using predictive models, for example, in our systems for many, many years now. So you may be familiar with the sepsis model, but there's many, many others. So predicting length of stay, predicting deterioration, all of those things have been there and have maybe popped up at you to say you should consider this in your day-to-day work. And now we're thinking of AI in more broad terms as we consider some of the newer applications such as generative AI. Next slide, please. And so again, I want to go through some basic sort of definitions of AI, machine learning, and deep learning. These are all terms you're going to hear, and I think this is a very good visual. So when you think about these models that we're training to learn how to do some of these functions, you can, so augmented intelligence is the overarching concept. There's data that can train to make these models work effectively. And within machine learning, you do the training more quickly. As you think about deep learning, that's when you have more complex models that require longer training and more diligence to ensure that the training produces appropriate results. And we're going to talk a little bit about some of the complexity and risk of ensuring that these models at the end of the day, when they come into the clinical space, are providing appropriate guidance for us because we recognize that there are patients on the other side of that. Next slide. And this is a slide that is, again, very in the weeds of how these training techniques work. And I left it here for reference for you to look at your leisure. So I won't go into all of the different methodology, but what this is here to depict is that there are different ways that these machine learning techniques teach the models. And so you can have particular approaches, and they're cognitive computing experts that get PhDs in this, that study the different training methodologies. So you can have supervised learning, you can have unsupervised learning, and then you can have reinforced learning. And a lot of the clinical models use the latter technique, the reinforced learning, to ensure that we are testing these models thoroughly, again, to have output that makes sense from a clinical perspective. Next slide, please. So now that we've sort of done the basic definitions and talked about the basics of AI, I want to talk about some trends in healthcare and what we're seeing today. Some of it you may have encountered and some of it you may not have yet, but this is a general overview. Next slide. So I think a lot of people have kind of pondered, why is AI so top of mind today? What has changed? And we really do feel like there was a change, and the change happened in the last 18 months or so when ChatGPT became a public version of generative AI. And you can see that things are changing even in the number of publications. As you look at this graph with JAMA publications and AI, you can see from 2014 to 2023, there was a 550% growth in the number of publications happening on this topic. And you can see after 2023 how that graph takes off. And that just tells us that this is becoming much more relevant in our clinical spaces today, and we have to pay attention. Next slide. So why is this time different? Part of it is increased awareness. As I mentioned, there's been a lot of AI used in our healthcare spaces over the years. And as we've been rolling out these tools, we've been doing it slowly and methodically and very thoughtfully integrating them into the clinical environment. So you may have seen some of the predictive models that I mentioned, but you may not have been aware that they're running in the background. Many of these things get tested in the background, and we're reviewing the data on the back end without necessarily even showing it to the clinicians until we see that it can be integrated as decision support, as something that can be presented to the clinicians to say, this is a time where you should pay attention. As generative AI became more and more relevant in our everyday lives, the change happened again about 18 to 12 months ago, where we now recognize that it is going to be used in applications across our day-to-day lives. And it's really important for us to think about, how do we use generative AI in the healthcare environment? One of the things that I was very engaged in my CMIO, CHIO roles is thinking through, how do we monitor the use in the clinical spaces? We had medical students, residents going online and putting things into ChatGPT, and we had to make sure that we're thoughtful and methodical, stop those kinds of behaviors, because of course we have to be considerate about patient data and privacy. And we recognize we're going to need to provide them tools because they're going to continue to develop across all other industries. So we have to be ahead of it in healthcare. Next slide. So what is happening at the highest government levels? There was legislation that said that we need to make sure that we have standards for AI. There's concern about safety and security. There's also a lot of conversation about health equity. We recognize that these tools are using data that's out there. We also recognize that that data is flawed. And so a lot of discussion on how do you ensure that what we're putting into those clinical environments is as equitable as it can be, so that we can provide guidance to our clinicians that is focused on health equity. A lot of discussion about protecting consumers and supporting our clinicians in the use of these technologies. We do want to promote innovation. We do want to make sure we're staying on top of what is out there because there's a lot of promise to AI. We haven't talked about that yet, but we will. And we need to make sure that we're using these tools responsibly, and the government bodies realize that and would like to get ahead of that. Next slide. So this is really interesting to me. The AMA did a survey of physicians, and there were a few findings that I found to be very interesting and worth discussing and delving into. About 65% of physicians say that they're enthusiastic about these new AI tools, which is fantastic. And 41% say that they're excited and concerned. Most of the concerns come from accuracy of guidance, health equity, making sure that these tools do not add an additional burden to our day. And the excitement often comes from the recognition that these tools can streamline many of the administrative tasks that we have had to basically, unfortunately, we've had to do these tasks with so many forces at the beginning of the talk that I mentioned that are coming at us that are both regulatory and as we think about clinical data exponentially increasing in volume on a yearly basis, we recognize that a lot of that is adding burden to the clinical job. And this cognitive burden that we're all experiencing on a daily basis, there's a lot of promise for AI to help with that in processing these huge amounts of information that we're now having to do on our own. So that was where the sentiments were coming from. And physicians did say that many of them recognize that they're using AI tools today in their practice, and they hope that more and more of these tools will continue to focus on the administrative burden. Next slide, please. I want to talk a little bit about some of the AI tools specifically that are out there today. And this is focused on Epic, but the other vendors are also looking at many of these things. So today, Epic is already integrating generative AI into their tools, and there are 3 things depicted here, but even since the slide was made, there are more things that Epic is rolling out. Ambient documentation, so you may have heard of some of the vendors that are doing this. Nuance is doing this. There are vendors like Abridge and Nabla and Suki and many, many other companies. But essentially what these tools are is that they listen in the background to the encounter, and then they produce a note at the end of that conversation. And Epic has actually integrated the tools into their environment, so you can use their app and it goes directly into the chart, and then you have a chance to proofread it. There are tools for billing and coding suggestions that are not live as far as I know yet, but are getting very close to being rolled out in some pilot organizations. And then there are the tools that are looking at patient portal messages. That's probably the top thing that gets reported to us by ambulatory physicians as their largest burden. As a hospitalist, I feel it less. If any of you practice in the ambulatory space, in addition to your hospital roles, that is usually the place where we hear the most. And Epic has come up with a tool that essentially will compose the message for you. There are a handful of organizations that are live with this today. There's some mixed reviews in terms of how accurate these messages are. So again, we're watching these tools as they're being developed. Epic in particular is also working on some summarizations. So looking at ways to summarize patient histories so that you can see the most relevant things for the physician. So for example, if you're a dermatologist, you'll get the history that's most relevant to their dermatological history. And those are very early in their iteration. But again, that's what we see coming in the future. And the things that are out there today, they are evolving very, very quickly. Epic in particular is working with Microsoft. Many other EHR vendors are working with large companies that are developing these tools very, very quickly, and they're figuring out how to integrate them into the clinical environments. Next slide. This is a depiction of sort of the large ecosystem of companies that are working on these tools. There's a lot of interest in healthcare. Many of these big players are investing a lot of funds into AI tools that will be used in the healthcare environment. And again, we have to watch this very carefully to ensure that as the tools get rolled out, they're rolled out in a very thoughtful manner so that we are, as we will talk about some of the risks, that we're very conscious of the risks. As you know, Oracle has purchased Cerner, so they are a big player in this space. The Microsoft partnership with Epic is another one to watch, and Google and AWS both really interested in this space and have entire teams devoted to this work. Many of them have clinicians, physicians on their teams. Next slide. So again, just a few of the things that are going out there in the marketplace. And I share this for awareness, not to go through each of the things that these companies are working on, but important to understand that, for example, Microsoft has now bought Nuance, and Nuance is rolling out DAX, and they're partnering with Epic, and that is an ambient listening tool. And they have Dragon, which is the sort of the older dictation system, the traditional dictation. And we're watching that to understand how these tools will be all integrated. Epic has rolled out the Hey Epic functionality, which is their dictation version. And it's interesting to see how that all rolls out. Oracle, of course, has their digital assistant. They have invested a lot of effort into these tools, and now that they have Cerner, it'll be interesting to see how that evolves, and very interesting to understand how Google and Amazon will play in this space. Next slide. So we talked a little bit about what's happening today, and I know that everyone's interested in hearing about some of the risks and also some of the gains, right? We hope that there will be a lot of positive things that will come out of this. And so what I want to do is cover some of these, and some of them are theoretical, some of them we're not sure, right? Because we can't predict the future. But these are areas that we should all be thinking about. And as we watch our institutions, our clinics, our practices roll out these tools, it'll be important for us to be aware of what questions we should be asking. Next slide. So some important risks, and I've alluded to some of these, but I do think it's worth calling them out. We talk a lot about bias, and we recognize the extent to which this could impact patient care if we're not thoughtful about these tools in the clinical environment. So really important to understand, how are they being tested? How are the vendors ensuring that they're minimizing the bias? And as these tools are being developed, these vendors are training the models. They're watching how effective the models are. It's important to ask the questions about bias that will impact health equity upfront and as you're using them. Transparency is going to be a big one, making sure that we understand what's behind the tool. How are they measuring the efficacy of these tools, and are they visible to the clinician? So if you are using technology, to ensure that there's transparency as to what kind of tools you're using in the background. If you have predictive models running in the background today, it's important to understand that if it drives any sort of decisions that you are making as the data is being presented to you. A lot of conversation about liability, of course, really important to understand how do physicians protect themselves as these tools are going to be in the background. AMA is doing a lot of work to advocate for the physicians in this space. Things like hallucinations, similar to bias, again, important to understand that that is part of what we understand happens with these tools, and we need to make sure they're well trained and that there's transparency as to the efficacy of them. We'll talk a little bit about the regulatory landscape and what is happening today and how AMA is advocating on the behalf of physicians in this space. We talked about privacy security. This is a huge one. We know, especially with the recent news, that this is a concern. This is a real concern. We are going to be all stewards of the patient data that we are utilizing. We need to make sure that we're educating ourselves, our colleagues, so that we don't have people going out on the internet and using ChatGPT, so that all the things that we're using are in a protected environment. Our clinical conversations, the communications that we have need to be in a secured environment. I think that it is a challenge because there's so much being thrown at us, and this will need to be at the forefront of everyone's mind. And then, of course, coding and payment is something that we're all thinking about as these tools are rolled out. As you know, there's a lot of conversation from a CPT perspective to make sure that we're supporting that process with the need for new CPT codes. AMA has been supporting the groups that are working on that. And we recognize that the CPT codes remain language that is shared amongst all of the EHRs and will be an important way for us to track the work that we are doing and the services that we're providing. Next slide. So some of these things, again, they're conjecture, right? There are things that we need to get ahead of. This doesn't mean this is going to happen. This means that we need to be aware of these risks, and we need to make sure that we are doing what we can to prevent some of these risks from becoming reality. And one of them is this concern about uneven progress. So there are organizations that have had a lot of success with their technologies, and they've been able to get ahead of new things that are coming out. They've been very innovative. And the concern is, of course, as they're able to get more and more of these tools, there may be a larger divide between organizations that haven't had access to these things. And so again, something for us to be aware of, think about how can we get ahead of that. Next slide. This is another one that I've heard a lot of people bring up, and something for us to understand is out there, this concern, and how do we get ahead of it. These AI tools are not just available to us, they're available to the payers as well. And the payers are going to be using them. And as we think about the prior auth challenge that we've all experienced, it's going to be important to make sure that we are watching how the payers are using these tools, that we're integrating them into our environment in the healthcare space. And as we think about burden reduction, this is a perfect example of an area where AI tools could be incredibly helpful to physicians. And we should be thinking about how do we roll them out? How do we utilize this technology to take some of the burden off of the clinicians? Next slide. And now this is the fun part. What are the opportunities for AI in healthcare? And I truly am enthusiastic about where I see this technology going. You know, as I mentioned, I'm a hospitalist, so I think about the inpatient space. I imagine these tools being useful in all spaces. And I imagine a day that we are, as we ingest all of this data that is being thrown at us, that we're going to be able to do that in a much more thoughtful manner. So wouldn't it be great if the computer knew what patient information we needed at what time and was able to give us that critical clinical data in the right time in the right place, so that all of these forces that we saw in the beginning are lessened. And as you see key opportunities, the majority of physicians that were asked about this, they see the key opportunities in that administrative burden. So all of that work we do that is truly administrative, that doesn't require the training that we had, imagine a world where some of that can be automated and it doesn't require our human touch. And if it does, only to double check the work. And this whole concept of augmenting capacity, there's so many areas where there are shortages of physician expertise. And there's a lot of opportunity for us to be able to, again, take some of the administrative burden off, take some of the cognitive burden off, and this technology help to augment our ability to do the work that we love. We did an interesting study in my previous organizations. I had a team of clinical informaticists, mostly physicians, some nurses, and our role was to look at the use of clinical technology at that organization. And what we found is when we intervened and we helped our physicians with the use of the technology, they became something like 50 to 60% more efficient, which meant that they were able to get through some of the administrative tasks in half the time. What was really interesting is we didn't find that they spent less time in the system. But what we heard from them is that they were able to spend time on the things that they loved, meaning they were able to actually sit and think about the patient and spend that time in diagnosing and analyzing and the things that we were trained to do. So as you think about these technologies, right, that was simple intervention to teach folks tools and how to use the EHR. Now imagine AI coming in and decreasing the burden so much that now that time is spent on the things that we love to do. That's where the promise of this technology is. Next slide, please. This is, again, a very busy slide. I wanted to throw it in here for just to give you some things to think about. And I like the way it depicts sort of where we are today and where we're going. And this is not exhaustive, and this may not even be the way it plays out. This is, again, the way that we envision this moving. But as you think about how much of AI technology is already out there, our radiology colleagues are using so many of these tools that are looking at images and showing them things that they may not have seen. There's tons of clinical decision support embedded in our EHRs. I've spent most of my career helping to design a lot of this clinical decision support. We're already doing the generation of responses. We're doing the generation of notes in many settings. So where is it going? I think what's interesting is that there's a lot that's going to happen again in the early days that we think will take away the administrative burden. And then as we look forward and these tools get better and better, the goal is for them to continue to be augmentative to our work and to continue to evolve in a way that they can make our day-to-day easier and easier. Next slide. So what's the AMA doing to ensure that physicians are at the forefront of the development of AI technology? I think this is really important. We all recognize that our technology colleagues are brilliant in the work that they do, and we absolutely need clinician voices in this conversation. It's not going to be successful if we don't have the clinical voice. And so I just want to review a few of the things that the AMA is doing. And I see that there's some questions, and we will hopefully have plenty of time for those. Next slide. So in November of 23, the AMA Board of Trustees put out some new principles. I talked about a lot of these things. I won't read all of these to you. I think what's important here is that the AMA has been advocating to ensure that there is accountability for how these technologies are enabled, to make sure that we're protecting our physicians and our patients from all of the risks that we talked about. And we continue to ensure that we stay on top of all of the different forces that are happening as these technologies become more and more integral in our clinical environments. And we continue to monitor them from all of these different aspects. Next slide, please. How do we prepare our physicians for the use of AI? All of us here on the call, it's coming at us fast and furious. The AMA has done a lot of research, and I talked about many of the research studies that have been performed, and we have a lot of resources, and there will be some links in appendix on the research and the tools that have been developed to help talk about how these tools can be rolled out. We also do a lot of convening where we are working with multiple groups across the country that are looking at how to create these AI governance models at your institutions. Also, how do we continue to partner with the new technology companies and such that are coming out so that we can be aware of what's coming out, and we will continue to participate in all of these different areas so that we can help drive the physician voice in this conversation. Next slide. So these are the links of all the resources. You can look at them at your leisure. I do want to make sure we get to questions, and I think that's my last slide. So let me open up the chat so I can see. I know there were a few questions in there. When AI rolls out more to the rural setting, do you anticipate a cost burden that will result in access to care gaps? That's a great question. It's hard to say. This is always a question, right? As these technologies hit the rural areas and the underserved urban areas, right? Many similar challenges that we're experiencing in both of those spaces. How can we ensure that there's equity in providing those tools? The way a lot of organizations have managed that is that as they rolled out some of these technologies, so things like remote patient monitoring, hospital at home, and some of these other things, they've rolled them out with the devices to help people have access to these things. Would be happy to hear what your institutions have done, but this remains a very challenging question and a very challenging topic we have to stay on top of. If AI functions give an answer to a situation case and the physician disagrees, will the physician have to argue their point of view, or will AI agent have to justify its finding recommendations? That's also a really good question. You know, the way that I envision these in the clinical environments is that it will present the information to the clinician, and ultimately the clinician will make the decision. I don't envision that it will be a tug of war between the AI bot and the physician, at least not in today's world, right? As the technologies evolve, I can't say what they will look like, but much like the predictive models that we have today, the way we present them, and this is again why it's so important to have the clinical voice in the design of how these things are rolled out. I had a whole team in my previous institution where that's what we did, right? They would give us the predictive model and they would say, what do you want to do with it? And we would go step by step and figure out where in the clinical workflow do you present that information. And that's what we would do. We would say, this is the sepsis risk score for your patient right now. We use this information to calculate it. Here are some potential next steps you may want to take. And ultimately, we left it up to the clinicians, right? That's the design piece. That's the art of rolling out these technologies and the art of medicine. So that's how I see it in the future. So there's a question about the regulation and accreditation of these systems. There are regulations today that require that the vendors for these systems that they have transparency to the users of what they're doing, and like what's the input information, how have they trained the models. Some of those regulations continue to be developed. The AMA has been a very strong voice for that transparency. And as the vendors are going to roll out these tools, it's also going to be a partnership with the institution, again, to make sure that it is implemented in a way that it makes sense for the clinicians, that is fair for patients, et cetera.
Dr. Lozovatsky, I think there are a couple above Dr. Gregory's, Dr. Bush, and
Oh, I'm sorry, I missed
that's
them.
it. Yes, and Dr. Jenkins. Yes.
Thank you.
Sure.
To comment on EU passing the AI Act last week, and will the US model laws similar? I am not familiar with the details of that, the EU Act. So let's take that back to our advocacy team and we can absolutely get you a response to that. Will the technology help simplify the medical record? As you know, the current hospital chart is terribly cluttered and hard to read. Amen. As someone that has spent many, many years trying to improve the current EHR hospital chart, I very much recognize as I use it that there's a lot of opportunity. The way that, it's interesting how these things evolved, and you're going to get a little bit of a history to as an answer to your question because I think it's important. But as EHRs evolved, what happened is we as physicians, we didn't know any better. And so we said to our technology colleagues, this is how I do things, put it in the computer. And they did. They put it in the computer. They took the paper process and they put it in the computer. And we all are now feeling the pain of that because that's not how they should have been designed. And as we have sort of chipped away at it, right, it was like playing whack-a-mole. You fix one issue and you get another one. What I envision the AI technology to do is to get around that. So instead of trying to continue to improve the user interface that has struggled because we took a paper process in a way that it shouldn't have been, AI will ideally in a future state compile that data and present it to us in a way that makes sense, in a way that is clinically relevant. That is how we probably should have designed these systems in the first place. But that's where I think the beauty of these tools is it can really help to decrease that cognitive burden. I'm looking at the chat. I feel like I've missed a few others.
Dr. Garofalo and then Dr. Gold.
Thank you.
Sure.
You're keeping me honest.
Sure.
I worry that we use AI more in processes such as prior auth pairs will actually subject more of what we do to a prior auth process under the guise of look how easy it is. But every PA decision gives an opportunity to erect a barrier to give care to a patient. All fair points. And sometimes technology can't solve the root of the issue, which is the entire prior auth problem, right? All very true. And I wish I had an answer for that, except to say that you're absolutely right. And my hope is that in addition to these technologies being rolled out, there will be continued efforts to combat the prior auth process. How does AMA envision protecting the primacy of the, did you mean privacy? No, primacy, okay. Of the clinician over AI support systems in the current environment of profit motive that tries to replace physicians with non-physician practitioners already. Well, the AMA has taken a very strong stance against the replacement of physicians, if you will. And the hope is that, again, technology will be there to support physicians to be able to work at the top of our license. That's the goal, and that's what the AMA has been trying to promote. Did that get to the root of your question or no?
Well, it doesn't. It just states the problem. How are we going to do it? In other words, are we going to make legislative entreaties? Are we going to go to the regulators? We're already losing that battle on the profit motive level, basically, both private equity and large healthcare systems. So that's why I phrased it the way it is. Do we have a strategy that can improve on what we've tried to do and not necessarily succeeded at this point?
That's probably beyond the scope of my area of expertise, but I think it's fair to ask the question. And again, through our advocacy folks, that's probably the right avenue of where you would want to ask that question. I don't know if the advancement of these technologies is going to impact that particular issue, and it might. And it's hard to say today how that's going to play into it, right?
I'm known for asking questions without answers. Thank you.
Well, Well, I am always the first to say when I don't know the answer. All right. I believe it will be essential for the organized medical staff to set the parameters how AI will be utilized at individual institutions. The organized medical staff is responsible for quality and safety at its institutions. We must make sure AI is utilized in a safe and positive manner. Well, I love that sentiment. And having sat in the administrative role in a healthcare institution not too long ago, I can say that that's fantastic. I do think it's going to be really important for the clinical leadership to drive that conversation. So thank you for saying that. That has been something that for many years I have watched play out in multiple organizations. And if the medical staff leadership is not at the forefront of these things, it's very hard for the technology teams to drive the changes. And they're the wrong people to drive the changes, right? So it's going to be, yeah, thank you. Yeah, it's going to be really important for you to partner with your technology teams, but really for the physicians to be the voice of how these things should be implemented. I suggest that CMS is busy drafting copies. Is that Dr. Gregory? Do you want to elaborate on that?
Yes, it is. It's a question for those conditions of participation, which are COPs, which are turned into elements of performance by the Joint Commission and end up being standards for accreditation. And I would imagine that CMS is busy drafting those COPs regarding AI, or do you know if they have any already in the works?
I do not know, but that's another question that we can get our advocacy colleagues to answer. And Lisa, will you keep track of the questions that we'll send to advocacy, and then we'll get back to you on those? I'm not sure.
Yes.
And I believe I saw
Thank
Dr.
you
Lester.
for
Yeah.
excellent. Thank you for an excellent presentation. Thank you.
Well, I am glad that you found it helpful. Thank you. I think I saw Dr. Lester with his hand up, and then I just saw a comment come up. The burdens of the EHR is crushing and major source of physician and nurse burnout. Are there AI demos available to show how that burdens in real world terms will be lessened? Oh, that is the question of the hour. There are real world demos of how the tools that exist today through the EHR vendors are being used. And they're so early that I don't think the potential is visible today, right? So I have personally seen many of these tools in the organizations that are using them. As you know, I sit in many of these informatics forums. So for example, the inbox draft. It has so much potential. Is it where it needs to be today? No, I don't think it's anywhere near where it needs to be today. The organizations that are using it are finding something like 20 to 30% accuracy, and the rest they're having to edit. But do we see the promise of where it's going? Absolutely. Is it a demo we can do today? I don't think so. I just don't think these tools are there. The rate at which they're being developed, however, is very quick. So I have a lot of hope. I see you're with your hand up. Do you have a follow-up question?
Well, I just to be sure that I couldn't quite figure out how to express that, but I think that the most crushing technology that had great promise and failed, in my opinion, it was dangerous, very dangerous to not only patient care but physician health. We have burnout rates, incredible burnout rates in both nursing and physician staff because of the technology of hope and promise of the EHR. It's been a devastating technology. The idea of having a new technology whose promise is undeniable, it's just undeniable. But the fact that we can't even master the I don't even go in the hospital anymore because I can't figure out how to use my medical. Can you imagine that the primary care doctors of the country have fled the hospitals? They've fled. They can no longer operate in our hospitals because of the EHR. And it's just a devastating. Now, the technology I ought to be able to talk to my computer and have it do exactly what I tell it to do. You know, the program should do that, but we have to learn how to use it, and we have to conform to the EHR. So the AI sounds fantastic. It sounds great, but to me, it seems like just another technology that's we're gonna have a whole bunch of different ones that only work with certain EHRs, and they won't be interoperable and all this other stuff. And we'll have this huge learning curve to figure out how to use them to do things. And so I think that the question is, you know, and some of this was touched on, you know, how will we be sure that they're interoperable and communicate that there must be standards, they have to be available to all EHRs and et cetera, et cetera. But I think it would really help. I mean, every time I hear AI, my eyes glaze over. I have no, I mean, you know, and then I want to go back to writing on paper, which incidentally was far more efficient in my experience. And especially when everything gets hacked and everybody has to write paper prescriptions, I think it's just great. But so the thing of it is, I think if we had examples to show the physicians, our members and the members of the AMA and physicians of the country, this is how AI will take us to the next level. And I think seeing those real world demonstrations of a physician using it and how it works and how easy it is to learn. In fact, the learning of the AI should be run by AI. So you should be able to walk up and say, what do I have to do next? And the AI would tell you what to do and it guide you as you clicked on the things and it would do things for you. We're not even close to that. You know, I think you need to be a ninja to use these things, but maybe a demonstration of real world products would really help us deter, you know, kind of get comfortable with the idea that this is even a step that we should be taking forward. Anyway, just those are just a lot of comments, but I mean, that's my experience with the AIs. My eyes glaze over and I want to go watch. Yeah, I get kind of overwhelmed by it.
If I might comment on that and provide a perspective. So first of all, I think we can do some demos of certain tools, right? They're proprietary, but we can demonstrate some things some data that has been captured on some of these tools and the promise of where it's going. I do want to comment on the EHR. I think that there's a lot of angst and we've all experienced it. So I will be the first to say that when I come in to do my shifts and it's not working for me, it's a very frustrating day. But I do think it's important for us to reflect on the fact that as the EHRs came up to be, so did all of the regulatory burdens and the quality measures and, you know, MIPS and meaningful use and all of those things. And so much of the burden that we experience is in front of us in that computer. And we don't always discern, is it because of the EHR or is it because of all of the other forces that I started the presentation with? And so I think it's important for us to be fair that as much as the technology may have not been the utopia that we expected, it also didn't fail at the rate that we think that it did. And as much as paper was easier at times, I have nightmares of my intern year running around and finding those charts and getting the faxes and going through the 8,000 pages and trying to figure out what's going on with my patient, right? So I think that there is definitely flaws and we have to recognize that it's not all the technology, it's so many of the other things as well. I see another hand up. That Dr. Bomba.
Oh, hi. Thank you so much. And just fantastic overview. Just amazing. I just hope the rest of the world can hear what you've shared here, or at least our House of Delegates. But my question has to do, and I did type it in the chat, has to do with the plethora of companies that are out there developing this. And my concern is there could be so much variability in their, quote, thinking capabilities, and that, you know, goes beyond, EHRs were an example. Well, yeah, there are some that were better than others, but we deal with that. It didn't directly necessarily affect care. This could, right? If the capabilities of X company aren't using all the data sources they should, and somebody else is, there could be very significant variability in care and put patients at risk and our decision making at risk. So just wanted to know your thoughts on that.
Yeah, that is a really good question. And honestly, all the years I've been in the CMIO, CHIO seat, that's probably what kept me up at night the most, right? Is the things that we do to change the technologies have real impact. And you're absolutely right. As we roll out these newer tools, the impact may be even more significant. Although honestly, it has been there, right? That pressure of making sure we get the technology correct. There is a lot of variability in the vendors, and this is again why it's going to be really important for all of you that I know are in med staff leadership to partner with your technology teams to really understand that transparency is going to be critical. It's going to be important for you to understand which tools are getting rolled out, how they're getting rolled out, that you have appropriate governance in your institutions. That's a whole other talk I could give on how to set up a process in your organization where you have the physician voices front and center to the conversation so that you can analyze what does this look like clinically, what are the potential impacts. And that's sort of a high level answer. There's a lot more to say in this conversation, but probably the best advice I can give you is to make sure you are closely connected to how these tools are getting rolled out and assessed in your organizations.
Right, and thank you for that excellent answer. I guess it also impinges upon the equity issue, right? More resourced hospitals or systems will have a better product than maybe the rural areas. And anyway, I just think there's huge questions come up as these products are developed for decision making. Yeah, thank you so much.
Oh, no problem. 100%. And the one thing I'll add to that is you're right on. You guys are in a seat where you can advocate for some of those resources. And that's going to be really important to make sure you do have somebody in a CMIO role, that you have these physicians that understand this and can partner with you. That's probably the best thing that you can do is advocate for the resources to be able to do that proper assessment from the beginning. I know we're almost at the top of the hour. Lisa, keep me honest. Did I answer all the questions?
Looks like
There's still some more.
I had something in the chat I wanted to ask about because
Dr.
I think,
Garat and Dr. Apparetti.
well, okay, okay, this is Dr. Gold. Okay.
Oh, am I up next?
Anyway.
Yeah, am I?
Go ahead, Matt. You were
Okay,
first there.
thank you so much for the excellent presentation. I was wondering about AI and mental health, and how are we going to add more safeguards for mental health? I mean, the recent hack would change healthcare. You know, we had to go back to paper prescriptions. You know, the controlled substances, we couldn't send any controlled substances in. And I'm just imagining, you know, once AI is in big time, how are we going to safeguard mental health?
You mean the mental health of the physicians, or are you thinking
the patients? Yeah,
the patients.
Mm-hmm.
So tell me a little more. Help me understand sort of how are we thinking of mental health of patients with AI?
Yeah, the privacy concerns, you know, and the misinformation and the biases. I mean, with mental health, we always have an extra layer, you know, of security everywhere. But now it's like with all the hacks, we're as exposed as anybody else. So with AI coming in and more chances of, you know, the misinformation or biases, what's going to be the future and how are we going to safeguard it?
I understand. Thank you for clarifying. Yeah, great questions, great points. These are all the risks that we talked about, right? And again, a lot of my answers come back to this because that's the critical piece, is it's going to be a partnership between all of our clinicians and the folks that are responsible for the safety and security of the data, which are your chief data officers and your CIOs and your chief information security officers that are spending their days and nights thinking about how to protect this information. And it's going to be important for them to understand the clinical relevance of that, right? So they're experts in the technology piece and protecting information from that perspective. I spend a lot of time with folks in those roles, helping them understand the criticality of these safeguards. How do we ensure that we build the system such that we segregate some of that data, particularly from a mental health perspective? So again, having that clinical voice in the conversation is going to be what is going to help them as they build out these tools and bring them forward.
Right. Thank you.
You know, that the comment that you made about having the EHRs there and then seeing things like MIPS come up, that sort of gets at my question about the prior authorizations. You know, I think one could argue that MIPS would never have come up if there wasn't a health record there to be able to gather that data. And that's where I wonder about, you know, and I think it's really critical that physicians are leading this, even in the companies that are doing the EHRs, because the payers' thought on prior authorization is, oh, we can use this to make prior authorization easier, which means we can do it more. Whereas the physicians should be saying, no, we need to do prior authorization less. And I think your point about the MIP stuff, I think, is sort of emblematic of that. I don't know which came first, the chicken or the egg, but I know MIPS came after the EHR, and I would argue that if the EHR wasn't there, MIPS wouldn't have come about. Does that mean that something else wouldn't have taken its place? No, not necessarily, but I do think there's sort of a cause and relationship there. And as we roll out new technology after new technology, I think we as physicians often find ourselves behind the 8 ball. Even though we try to get ahead of it. And I don't know why that is. I don't know if it's because we're not involved at the very beginning of this, but I think, you know, this is another chance to make sure that physicians are out in front on this to try to prevent some of those mistakes of the past that have seen us get steamrolled. So thank you.
No problem.
I'd like to ask a specific question. I put it in the chat. And this is, I think, at least in outpatient care, one of the critical bottlenecks is translating the interaction with the patient into the medical record. And too often, you know, cliches are put in, nuances are left out, and forms are filled out that are no longer necessary. In fact, you know, Medicare wanted all these bullet points. They finally went away, but everybody's now cloning things, you know, pages and pages of useless stuff. So, but I do know, as a neurologist, I'm very sensitive to nonverbal parts of communication. I know that nuance, it looked exciting a few years ago when they came out with it, because I've been thinking about this for a long time. If you're going to have an automated reconstruction of a doctor-patient interaction, you have to be able to understand the nonverbal communication of both sides. Because as you know, I mean, if you say, here's the way, this is called prosody, okay? This is the melodic envelope of speech, not to mention body language. So if you say something like, I'm going to kill you, as opposed to say, I'm going to kill you, it means completely different things, right? And I know that there is software out there, I think it's a Boston company, that can distinguish some of this. I don't know whether that's been integrated in the Nuance project or not. It sounded like they were. Could you update us on that? Because I think the bottleneck is, you know, putting everything into the record accurately. And if that could be done automatically, it would give us plenty more time. And yes, prior authorization. And by the way, I understand value-based care much less than I understand artificial intelligence. Nobody has ever defined value-based care sufficiently so I understand it. Anyway, but go back to my original question on the recording of the interaction in the office.
Yeah, so I can give you sort of high level the technologies that exist today, and there are many, Nuance being the first in the market, but now there's so many, I can't keep up with all of them. They're pretty good. They're getting better in getting those nuances. They're not perfect, but the folks that use the early iterations, I think, have been a little bit burnt because they weren't as good, and they had a human on the other side of it. Now that they have evolved to being fully AI, tools, again, they need some training. It takes some work, but the feedback we're getting is quite good. I have talked to folks that have used multiple of these technologies, and they're, to your point, not as good as being in the room with the patient. it takes a little bit of adjustment where you start to articulate some things you may not have. So when you're speaking with the patient, you may articulate what they're trying to say in a different way, and then that gets documented. So it does take a little bit of getting used to and an adjustment from both the physicians and the patients a little bit. But I do think that the video technology is moving very quickly, and we'll get to a place where there will be what you're describing. In fact, I'm not familiar with the company from Boston that you mentioned, but there is a company that is out of Chicago actually called Artisight, and they're doing a lot of this analysis of video, and they're using it for all kinds of purposes. And there's many others, but that one is developed by a physician that I think is actually very promising of all the things, as you sift through all the noise that we see. I know I want to be respectful of everyone's time. I know we're past time, and I want to thank you for your engagement. I really appreciate how engaged all of you were and all the great questions, and happy to connect. I'll be at the annual meeting, so I'll hopefully get to meet some of you in person and connect some more then.
Thank you so much, Dr. Lozovatsky. We appreciate every moment with you. Thank you.
Thank you, everyone.
Thank you. Wonderful.
Thanks, everyone. Bye-bye.
David, you're going to call me?
I have another call after this. Tomorrow will be okay.
Tomorrow's
Call you
fine.
tomorrow.
Good.
Yeah.
Thank you. Okay. And then,
I guess we're through.